Hi, everybody, and welcome to the inaugural Pain Management Service Line Journal Club. Thank you very much for, again, lending your free time, your precious free time, to join us, and us being myself, Pankit, and Alyssa, who will be on in the call a little bit later. So tonight we'll be discussing 3 articles, and I hope you find them useful and informative. We'll start off with Pankit, who is a PGY 5 at Northwestern University, and he'll be presenting an article on image-guided cryoablation for the treatment of painful musculoskeletal metastatic disease. And without further ado, we'll launch it off to Pankit, and afterwards I'll take the floor for a presentation on the treatment of lumbar stenosis with epidural glucocorticoid injections in a randomized trial that appeared in the New England Journal of Medicine recently. And then Alyssa will finish it off finally with an article on interventional radiology and pediatric palliative care. So without further ado, Pankit, I'll kick it off to you. The floor is yours.
All right, thank you. Can everyone see can we see my desktop? Hello?
So David will make Pankit the presenter.
Yeah, it should be. Oh no, that's mute. You should be the presenter. In your toggle box, can you see show my screen? Like this giant play button.
Let's see. This one.
Yep.
All right, great. All right, so everyone can see my presentation. All right, so today I'm going to talk briefly about this article that came out just this year in Skeletal Radiology. The name of the article is Image-Guided Cryoablation for the Treatment of Painful Musculoskeletal Metastatic Disease, and this is a single-center experience. So the background of this article is just that bone and soft tissue metastases are a major cause of morbidity in cancer patients. We're discussing cryoablation today. Obviously, there is RFA available for these lesions, and the advantages of cryoablation and the reason the authors choose and prefer cryoablation is that they can have visualization. So on CT, you can visualize the actual ice fall that's forming. If anyone's ever done a cryoablation, you know that it's just hypodensity. You have geometric accuracy, so you can actually place multiple probes to get a geometric, a very accurate geometric ablation zone, and you have decreased intraprocedural and post-procedural pain, which has recently come out versus RFA. So the methods of this study was that it was a single center, it's a retrospective study, so they did chart reviews. It was an intent to treat trial, which means that they basically counted patients as treated if there was an intent to treat. And they had follow-up at 24 hours and 3 months, again, by chart review. And patients were excluded if follow-up was not available. The major outcomes that they looked at were the VAS pain score, which is a visual analog scale, which I'll show you in a second. They looked at the morphine equivalent dose that the patients were taking prior to and after treatment. They also looked at subsequent treatments. So these patients may have went on to have other treatments due to either continued pain or failure of the initial intervention. And then they also looked at complications, which we'll talk about more. The inclusion criteria were basically just patients with painful metastatic disease and whom primary treatment strategies, so usually either medical management or external beam radiation therapy had failed or were declined. And then patients at risk for further morbidity, which they didn't really go into how they define that, and then patients with metastatic disease who are not surgical candidates. So this is the visual analog scale. It's really simple. You know, this is supposed to be a 10-centimeter line, and they mark on that scale where their pain is. The left end of the spectrum being no pain, and the right end of the spectrum being the worst pain of their life. And that has been, you know, shown in prior studies, you know, a long time ago to be pretty accurate and internally reproducible, obviously. So the methods of this for the actual procedure, they use CT guidance to place the cryoablation probes. They usually had anesthesia on board, but they didn't. Only 10% of the patients had general anesthesia. Most of them had moderate sedation. They used cryoprobes ranging in size from 13 to 17 gauge with a 2-centimeter 2x1 to 3.5 by 2 centimeter ice ball, and they used 2 10 to 5 minute freeze-thaw cycles for each lesion. So as far as the results of this procedure, they were able to recruit 50 patients, and they ablated 54 tumors within these patients. So you can see the distribution of the lesions that they ablated. So these were both osseous and soft tissue lesions. Several lesions were in the axioskeleton, and several were appendicular. So what's interesting to note is that there were pending fractures, or they thought the patient was very close to fracture, in one iliac bone lesion and a couple of femoral lesions as well. There's also soft tissue lesions, which included small spaces such as the masticator space or pteropalatine fissure, and then other larger soft tissue lesions in the psoas muscle, etc. So, as far as this graph right here shows morphine use pre and post cryoablation. So they had they showed a significant. I'm sorry, this is the VAS pain score. They showed a significant decrease in the overall VAS pain score, both at 24 hours post-operative and also 3 months after cryoablation. They also showed a significant decrease in the morphine equivalent dose. So whether they were on fentanyl or any Dilaudid or anything like that, they just made a morphine equivalent dose, and they showed a significant decrease from around 300 to around 100 post-procedure and 130 3 months post-procedure. So getting into the nitty-gritty of the actual patients and the procedures, so 18 patients actually had segmentoplasty concurrently. So these were obviously for osseous lesions. They didn't say which patients specifically and what locations had segmentoplasty, but I assume that some of the femoral lesions and some of the more precarious axial lesions had segmentoplasty concurrently. 4 patients also went on to have external beam radiation therapy. 1 was planned, and 3 were due to symptoms. So, you know, these could be counted as possible treatment failures. 2 patients had no immediate relief and increased pain at 3 months, and then 1 patient had immediate relief but increased pain at 3 months. So it seems that immediate relief was a decent predictor of pain relief at 3 months. As far as complications, they only had one procedure was aborted due to the inability to traverse the lesion. They had two minor complications, which was ablation beyond planned region. A couple of patients had some numbness and peripheral nerve damage in the region of ablation, though this is only counted as a minor complication. There was also major complications, and those were both. I'm sorry, I skipped the neuropathy, but the major complications were proximal femoral fractures, and that was after ablation and cementoplasty. that happened in two patients, and then 2 patients also had transient neuropathies. So this paper basically shows that cryoablation is a effective technique. It doesn't compare to anything else, obviously, but it shows that it's a effective and relatively safe technique. Obviously, there are alternative therapies to cryoablation, including bisphosphonates, some nuclear medicine agents like quadrimeps, which is for bone lesions, chemotherapy, and obviously external beam radiation therapy, which has been pretty much the standard of care. As far as RFA versus cryoablation, several authors, including the one listed here, have shown significantly less short-term analgesic requirement and shorter hospital stays for cryoablation, and their complication rates were similar to prior publications. So the conclusions that they took away from the study was that cryoablation is effective for painful osseous and soft tissue metastases and can be used in conjunction with cementoplasty. They were able to have decreased narcotic use for patients, which reduced some morbidity for these patients. And then the major complications occurred with the proximal femoral lesions, which were complete fractures. So as far as criticism of this study, obviously the study design is not ideal, right? So it's not a randomized control trial, large randomized control trial. It was a retrospective study, and they used the visual analog pain scores obtained from chart review, so it wasn't even that they saw these patients in clinic and then were able to assess these patients. This was mostly from chart review. It was not comparative, so they didn't really compare cryoablation to anything such as a sham procedure or even to RFA. The one thing that I picked up from the study is that there were some confounding factors. 18 patients had cementoplasty, so it's unclear, I would like to think that the cryoablation was responsible for the majority of the pain reduction, but you can't say that it wasn't cementoplasty. As we know, vertebroplasty does reduce pain without any other ablative procedure, even in metastatic lesions. 4 patients also had external beam radiation therapy, and 3 of those were needed due to continued pain in the region that was prior ablated. And then there's some things that need further clarification. So I wonder if some of these lesions had both a soft tissue and bone component, or are these all bone lesions? And even then, where were they located within the bone? So were they mostly medullary space lesions that responded, and then the cortically based lesions, which I would assume caused more pain, didn't respond, or maybe those did actually respond? So I think the location of the lesion within bone is actually would have been an interesting thing to report. It is stratified by primary tumor or histology. So, do prostate lesions not respond as well as breast lesions, for example? So it'd be interesting to know that. And then as far as the proximal femoral lesions, it would be nice if they had included figures of where those lesions were, just so that we could see them, and that this might be something that people want to avoid in the future, given that their two really major complications were due to these in patients with these lesions. So as far as future studies, I think, of course, the holy grail is a larger randomized controlled trial. I think stratification by the primary tumor would be nice, and it would be interesting to look at quality of life issues other than pain, such as mobility, because that's something that is also important in these patients. Obviously, cost comparative effectiveness compared to external beam radiation therapy and RFA. I know the whole comparative effectiveness thing is cliched by now, but I think it would be an interesting study. And then collaborative studies, I think, if they did a collaborative study with palliative care or orthopedic surgery or neurosurgery, it would be interesting. So that's basically all I have. Thank you for your attention. Does anyone have any questions? I don't know if I can hear people right now.
All right. Dushan, did you want to wait till the end for questions, or you want to pause here? I just typed to everyone.
Yeah, I think that's a good idea, Dave. Yeah. So if anyone, that was a great presentation, Punkit. Thank you so much. That's really a comprehensive presentation as well as interpretation. So really appreciate that. I think if anyone comes up with questions, we can have, Dave, if that's okay, we will just save them for the end, and feel free throughout the presentation, and hopefully Alyssa will be on the call afterwards during her presentation. If anyone has any questions, just raise your hand, and we can try and address it at that point. Otherwise, I think we'll leave some time at the end.
Great. Okay, I'll make you the presenter then. And again, like Dushan said, at the end when we're asking questions, you guys can raise your hand. We'll unmute you, or we will, or type it into the question panel. We'll be able to read them. Okay. And Dushan, I just made you presenter, so.
Okay. Hi, everybody. So my name is Dushan. I'm part of this pain management service line. Again, thank you for joining us. I've been part of the pain management service line since March 2013. We've now grown to 9 members. I'm very excited that everyone could make it. This is our inaugural event in terms of a journal club, and we hope to have more in the future. So the article that I'll be presenting is a recent article, came out just in July, on the July 3rd issue of New England Journal of Medicine. And as Punkit alluded to, in the field of pain management in general, the holy grail, really as anywhere, is to get these large randomized control trials. And in the field of pain management, really there aren't too many landmark trials that we can really point to, and this is serving to be one of those landmark trials. And the reason that it's serving to be one of those landmark trials is because it addresses and talks about an issue which is very prevalent, as well as a treatment modality which is extremely prevalent and is only going to expand as the future goes on. And the issue is, or the condition that this article addresses is spinal stenosis, and the treatment modality is of epidural glucocorticoid injections. This is a large randomized trial, and we'll hop right into it. And before I describe the trial, I'd like to just kind of go over what lumbar stenosis is. So lumbar stenosis is defined as a condition where the spinal canal is narrowed, and it can be narrowed and even compressed. So as I said, it can be the cord, or also it can be the nerve roots, which are emanating from the cord. The general etiologies for lumbar stenosis are aging, disc herniation, or even tumor. Now, as far as the epidemiology is concerned, it's a very, very prevalent condition. Some studies estimate it to be about 12% of elderly males affected by lumbar spinal stenosis, and 21% of those in the retirement communities. In fact, even in the last year, in those Medicare populations, over 2.2 million lumbar epidural steroid injections were administered. So it's certainly a big patient population. It's big business, and a very, very common procedure that's performed. Now, the signs and symptoms of these patients, how do they end up at the treatment aspect of where they see a pain management physician? So from a diagnostic standpoint, an average patient would come into to the office and complain of symptoms of back pain. Now, generally speaking, the lumbar stenosis has a typical pattern where there's both back pain as well as leg pain. And in fact, usually it's lower extremity pain, bilateral lower extremity pain, which is greater or disproportionate than that of just back pain alone. So a typical patient would have weakness, pain, or tingling of the legs, as well as back or buttock pain, radiating of both legs, or it could be unilateral to one leg. These signs and symptoms usually are positional, that is to say they worsen with extension and improve with flexion or sitting. They're often referred to as pseudoclaudication because they can mimic patients who are vasculopathic. Oftentimes, IR physicians will come across, and we do as well, these CTA runoffs and whatnot during our residency on these patients who are vasculopaths, and they'll have true claudicative symptoms. That is to say, they'll have pain with exertion that improves with rest. However, the positional nature of this pain differentiates vascular claudication from lumbar stenosis. Now, in terms of the treatment options, in general, there are three major limbs. There's conservative treatment, generally NSAIDs, which are tried initially. What we're going to be talking about is the realm of the epidural injections, which can have generally two approaches, which is a translaminar approach, transforaminal approach, excuse me, and interlaminar approach, posteriorly and laterally respectively. The third option is surgery. So generally speaking, surgery is, the surgery that's typically performed is a laminectomy, in which there's decompression of either the spinal cord or the nerve roots that are being impinged, and that has been proven to have about a 70% success rate, although it's mired with its own complications and is generally reserved for patients who've had symptoms for 3 to 6 months and without any relief on conservative treatment. Now we'll get into the trial. So the name of this trial is the LESS trial, and that refers to the lumbar epidural steroid injections for spinal stenosis trial. And this is to compare the effectiveness of epidural steroid injections plus anesthetic, lidocaine in this example, versus using lidocaine alone. There's been a lot of anecdotal and smaller studies that have proven advantages. Some have proven no advantage over using steroids and adding lidocaine or using lidocaine alone. So this served to sort of dispel some of the myths that are out there. It was a large multi-center trial. There are 16 centers that were involved, and it was performed between 2011 and 2013. There were 400 participants, 26 interventionalists who were involved in this trial. There were two groups. These participants were separated into two groups. One, as I said, received lidocaine alone, and the other group who received glucocorticoids and lidocaine in conjunction. The outcomes were measured at 3 and 6 weeks. And as Pankaj alluded to, there's various scores that are used in pain management. There's n number of different types of surveys and questionnaires, but the two that were employed in this, amongst others, the principal ones were the Rowland-Morris Disability Questionnaire, or what I'll refer to as the RMDQ questionnaire, as well as the rating of intensity of leg pain. The RMDQ questionnaire is basically associated with the disability questionnaires and it ranges from 0 to 24, with higher scores indicating greater physical disability, whereas the rating of intensity of leg pain is from a 0 to 10 scale, 0 being no pain, 10 being the worst pain that you can imagine. So as far as enrollment, randomization, follow-up, I did allude to the 400 subjects, but how were they selected? There are over 2,224, to be exact, patients who were initially assessed for eligibility. A number were excluded who had, and the exclusion and inclusion criteria, I should mention, were the patients who would be included were those who were greater than 50 years of age, those who had spinal stenosis diagnosed by imaging, and those who had, on that 1 to 10 scale, a score greater than 4, or a score greater than 7 on the RMDQ scale. Patients who were excluded were patients who did not have stenosis on imaging, patients who had a history of lumbar surgery, or who had received epidural glucosteroid injections within the previous 6 months. Now, once the patient selection was cut down and the 400 number was achieved, they were then split up into 200 and 200, two groups of 200 each, and one group to receive lidocaine, the other group to receive glucocorticoids plus lidocaine. Now, basically, they were given injections at baseline and were given with the option to have a repeat injection at 3 weeks if deemed acceptable by the clinician, and also on request of the patient. And we're told that after their second follow-up, which was in 6 weeks, they'd be switched over to the other limb of the trial, ensuring that they would get both treatments. So out of this, you could see that it was a relatively good follow-up. 193 patients completed the 6-week assessments. So now, as far as the patient participant profile, they did a pretty good job of, and I don't know if you can see my mouse here, but they were selecting all the patients, and all the criteria were fairly evenly matched up. And one of the things that we'll come back to in terms of the critiques of this study was the duration of pain. So basically this is the number to concentrate on, this 40 and 24 number, because the patients who had duration of pain less than 3 months, you could say maybe subacute pain, there were a lot more patients with a shorter duration of pain in the lidocaine group than there were in the lidocaine plus corticosteroid group. So the where, when, and how. The where we talked about, there are a number of centers that were employed. There were 26 interventionalists who participated in the study, and these included board-certified anesthesiologists, physiatrists, as well as radiologists with expert in administering epidural injections. As far as the where exactly, the where was determined by the level of maximum spinal stenosis, and a level below that area of maximum stenosis was chosen for the interlaminar approach, and for the transforaminal approach, the nerve root level where the most pain occurred was utilized, and if there were allowances for multiple levels if there was pain or symptoms, weakness at multiple levels. As far as what was used, the typical sort of cocktail which is employed is of glucocorticoids and lidocaine, 1 to 3 cc's of 0.25% to 1% lidocaine, followed by 1 to 3 cc's of various steroids. It could either be dexamethasone, methylprednisone, amongst others, or an equivalent volume of 0.25 to 1% lidocaine was used alone. So as far as the outcomes of this study, as I mentioned, two scales were employed, and primary as well as secondary outcomes were measured. Now, it's kind of a busy slide, but I think the main thing to concentrate on is that there was a relative, and this is the lidocaine group, this is the glucocorticoid plus lidocaine group. At 6-week follow-up, the results were that there was about a 3-point improvement in this RMDQ score in the lidocaine group, and a 4.2 number improvement in the steroid plus lidocaine group, which actually turns out to be not statistically significant. Now, as I mentioned, the primary outcomes were using these scales. Basically, the pain scale specifically said buttock, hip, or leg pain, and compared to the previous weeks, how much improvement did you see? Secondary outcomes, just regardless of a pure number or numerical score, were also trying to quantify clinical significance. So improvements of 30% or at least 30% were deemed as a minor or partial success, where a substantial clinical improvement of 50% was the goal, and that was a secondary outcome which is also measured. How are these patients assessed? So the patients were assessed using telephone calls, in-person interviews, and also mailed questionnaires. In addition to just a pure assessment, there was also quantitative assessment of these patients' blood levels. Now, we know glucocorticoids, when taken long-term, can inhibit the hypothalamic pituitary axis and can have various systemic effects in long-term, causing osteoporosis, amongst others. So therefore, there was serum cortisol was also measured for these patients at baseline, at 3 weeks, and at 6 weeks. And this was to determine the level of systemic absorption and to also kind of quantify the adverse events. And in speaking of outcomes as well, basically the number again was to concentrate on, going back to that slide, is a 3.1 and 4.2. Not really that much of a statistical difference, which I'll come back to in just a second. And we'll also talk about the interlaminar and transforaminal approaches. As far as the secondary outcomes that you can see from these charts, the black line is highlighting the lidocaine-only group, the red line, the red interrupted line, the glucocorticoid plus lidocaine group. So as you can get a feel for it, there really isn't that much of a difference on these secondary outcomes either. However, with that being said, the secondary outcomes that were found to be somewhat statistically significant was that on surveys, particularly of this SSQ symptom score, which refers to patients reporting their own symptoms, there was symptoms related to depression on the SSQ satisfaction scale were more so of those patients treated with glucocorticoids to a tune of 67% versus those who were treated with lidocaine only 54%. Also, there was overall this patient satisfaction was higher with glucocorticoids than with just lidocaine alone. Now, going back to the interlaminar and transforaminal approach, the interlaminar approach basically showed a better physical function and showed a decreased amount of leg pain at 3 weeks. As you can see here, there was a better improvement in 3 weeks with the steroid versus the lidocaine alone, but really at 6 weeks there was no significant benefit seen. So therefore, there was a minor statistically significant difference seen in short-term steroid group versus just a lidocaine group, which essentially regressed to the mean or averaged out over 6 weeks. So as far as additional summary outcomes or adverse events are concerned, there's a relatively significant amount of adverse events that were reported with both groups, 22% in the glucocorticoid group and 15.5% with the lidocaine-only group. And the adverse events, interestingly enough, were also increased in the group treated with transforaminal approaches versus the interlaminar approaches, which kind of makes sense. Interlaminar approaches generally felt to be safer. The transforaminal approach is argued by some to be more effective, and we'll come back to that in a second. Now, of noteworthy of note is that basically about 10% of the patients who were treated with the glucocorticoid group reported some alteration in their serum cortisol levels. So that is indicating, or direct indicator, or indirect indicator, I should say, that there was some suppression of the hypothalamic pituitary axis occurring in 10% of patients, which is a relatively significant number of those treated with steroids. As far as the discussion goes, so overall, the bottom line is that there is no significant difference between group differences in the RMDQ scores at 6 weeks between the groups treated with glucocorticoids and lidocaine versus those of lidocaine alone. The transforaminal approach, in addition, showed no significant advantage over the interlaminar approach, and there was significant suppression of the hypothalamic pituitary axis, indicating systemic absorption of the corticosteroids. As far as the critique in this article goes, there is no real placebo group that was administered. The group at the end of the article in their discussion do address this. They mentioned that, especially given the fact that the patients reported this higher satisfaction with glucocorticoids or less depression, that they did not include a pure sham injection group and thus couldn't assess for whether lidocaine alone conferred the benefit or how much was that. How much of all of this is placebo effect? So that's one critique. In addition, as far as we alluded to earlier, the duration of pain was shorter in the lidocaine group alone. So that can also be a confounding variable because potentially patients who have a shorter duration of pain would respond better, therefore potentially equalizing the results. Although they say they did account for this in their regression analysis, it is a confounding factor, particularly given the fact that this sets out to be a landmark article. So as far as the conclusion goes, at the end of the day, the treatment of symptoms of lumbar spinal stenosis, which is a very prevalent condition, and often treated condition, as we said, both conservatively with medication as well as epidural steroid injections and or lidocaine injections and surgery. Epidural injections of glucocorticoids plus lidocaine offered minimal or no benefit over epidural injections of lidocaine alone at 6 weeks. Thank you, guys. So if there are any questions, I'd be happy to take them at this time. Otherwise, I see Alyssa is on the call, thankfully, few, and we can shoot it off to her. Thank you, guys.
All right. So again, if you guys want to say something, go ahead, raise your hand. We'll unmute you, or you could type in questions to the question panel. Alyssa, I made you a panelist. I'm going to make you a presenter now, and you should see a dialogue on sharing your screen. Yep.
Can you guys hear me?
I think so.
Yes.
Okay. I wasn't sure if the mic just turned on automatically. Were there any questions about the previous presentation, or should I just go ahead and get started?
I think we can go ahead and get started, Alyssa.
Okay, sounds good. All right, hi everybody. Sorry I'm late. My name is Alyssa Lampe. I'm a third-year medical student at USC. Let me get rid of this. All right, that's a little better. So yeah, I'm a third-year medical student on USC. So today I'm going to be presenting on IR in pediatric palliative care. So this study was published in Pediatric Radiology in January of this year, and this is a review article written by Derek Roebuck. So most patients that end up on the PEDS IR palliative care service are those that have congenital or neuromuscular diagnoses rather than cancer, and a lot of them have more than one diagnosis. Many kids that need palliative care have conditions that are rarely or never encountered in adults. I just added this table here on the left so that you can see sort of some of the conditions that you'll encounter sort of in PEDS IR palliative care. There's a really wide and diverse range of conditions, and in addition, duration of survival within pediatric palliative care. And only a small minority of these patients are referred to IR, because even in terminal malignancy, severe pain that doesn't respond to opioid analgesia is relatively unusual. A study from Children's Hospital Boston showed that only 4% of children dying of cancer required epidural or intrathecal infusions for pain management. The usual indications for IR involvement in pain management are opioid resistance, opioid-induced hyperalgesia, limiting adverse effects of intravenous opioids, or neuropathic pain. And there are roles for IR beyond pain management, but I'm going to go ahead and touch on that a little bit first. So one of the things that IR can do in this patient group is a celiac plexus block, in which a needle is inserted into the back and imaging is used to guide the needle to the celiac plexus nerves. And there's a dye used to make sure the needles are in the correct place, followed by the injection of the anesthetic. Nerve blocks are usually within the field of anesthetists, but in certain locations, imaging is required to perform the procedure well. That's traditionally been done under fluoro or CT, and more recently with cone beam CT or endoscopic ultrasound. Celiac plexus neurolysis with ethanol has been used successfully in children with neuroblastoma and hepatoblastoma with difficult to manage pain. And then ablation of painful lesions is something I'm sure we're familiar with in older patients with cancer, and that's done, albeit rarely, in kids as well. And then finally, Roebuck discusses the embolization of AVMs. So many vascular anomalies are incurable, and they're associated with pain, ulceration, and bleeding. So palliative embolization can control these consequences. There is some post-embolization pain that can last for about 3 to 5 days post-embolization. So this is a figure from the paper that shows a palliative embolization of an unresectable craniofacial AVM in a 7-year-old girl. So figures A and B show that the AVM is supplied by the right internal carotid and maxillary arteries. And after several embolization sessions using ethylene vinyl alcohol copolymer, you can see in figure C, there's a huge cast of embolic material that's present in the malformation and its feeding vessels. But as you can see in panel D, despite embolization, there are some abnormal vessels that still persist. So another role of IR in this patient population is the management of ascites. So intractable ascites in this population is rare. Ultrasound-guided paracentesis can be used in patients that have a short life expectancy, but more often a longer-term solution is used. So peritoneal venous shunting is an entirely internal form of continuous peritoneal drainage, which is the figure on the bottom left, which shows that you've got a peritoneal catheter that's connected to a central venous catheter, usually draining into the IJ or the subclavian vein by a subcutaneous port chamber that contains a one-way valve with a pump that the patient uses to drain the ascites into the venous circulation. And then finally, TIPS. can also be used in pediatric patients that have portal hypertension, which is uses an intrahepatic connection between the portal vein and a systemic vein, which is usually the right portal vein and the right hepatic vein. So another role of PEDS-IR in palliative care is the management of pleural effusions. Malignant pleural effusions are pretty rare, but they can be caused by several conditions, including hepatitis, lymphohistiocytosis, lymphatic hypoplasia, and carcinomatosis. So pleurodesis is one modality that can be used, which is adhesion of the pleura. And when that's not appropriate or is unsuccessful, a long-term drainage catheter or drainage port can be inserted. And then another role of PEDS-IR that's a little more common is dealing with feeding difficulties. So almost half of patients on PEDS palliative care have a G-tube, and the insertion and maintenance of these tubes is a large part of many pediatric IR practices. So this figure that I have at the bottom shows the balloon dilatation of the esophagus in a 3-year-old girl with dystrophic epidermolysis bullosa, which is another, this esophageal balloon dilatation is another role that PEDS-IR can play in palliative care. So you can see that a contrast study shows a stricture of the esophagus at the level of the left main bronchus, which is a common site in dystrophic epidermolysis bullosa. So in figure B, there's a 12 millimeter angioplasty catheter that's positioned so that its radiopaque markers at each end of the balloon straddle the stricture, and they've got little arrows pointing at those markers. And then in C, you can see that there's a waist or a little contracture at the center that confirms the presence of the stricture. And then in D, as they inflate the balloon, you can see that little contracture goes away, and they're confirming that with fluoroscopy. And then another study showed that this technique produces freedom from symptoms for an average of 5 years after this is done. There are a couple other palliative procedures mentioned in this paper, including stent insertion for airway compression in cardiac disease or palliation of malignant obstructive jaundice, also nephrostomy and anterior grade ureteric stenting. So although this isn't really a traditional sort of clinical trial or study type of paper, there are a few sort of critiques I had of it. It doesn't really address how the IR methods that are described in this paper are superior to more traditional methods. And it doesn't really address the future of pediatric palliative IR, since there are a lot of procedures that are used in adults, like I mentioned, like ablation, that have been adapted to kids that are kind of rare. And there's also, I think, a big frontier for sort of development of new procedures, since kids have a more diverse range of conditions that could potentially be treated by IR. So in conclusion, PEDS palliative care is currently a small branch of IR. Procedures that are more commonly performed in adults have been adapted for PEDS-IR, but PEDS patients also have unique needs that I think could be met by the development of new procedures and things like that. And PEDS-IR plays a small but significant role in alleviating the suffering of patients unresponsive to traditional care. So the implications of this sort of review show that interventional radiologists should be a part of the care team in pediatric patients with certain life-threatening conditions in which they have a role to treat some of these problems, like I mentioned earlier, like the esophageal strictures or ascites or conditions like that, where there is a significant role for IR. And then interventional radiologists involved in palliative care may need to have a broader range of skills to address the more diverse needs of this population that has life-threatening illness than possibly in some other branches of IR. So for future directions, expansion of the role of palliative care, I think, is something that has been happening nationwide. And there needs to be more studies comparing the outcomes and pain management with traditional treatment versus IR in children with life-threatening conditions. And as I mentioned, there's some potential here for new horizons in treatment modalities for IR. So that's it. I'd be happy to take any questions if you guys have any.